Hello and welcome to another edition of Professor Speaks. Today we're going to be talking about upcoding and medical billing. But before we get into that, I'd like to remind you to hit subscribe and hit the little bell for notifications. Hello and welcome to another edition of Professor Speaks. My name is Alex Hernandez. Alongside me as always is Dr. Craig Stern. And for our topic today, we kind of delved into this off screen, of course, because there was an article about upcoding and medical billing. So I'm sure what I said there doesn't resonate with a lot of you. So what exactly is that?
Yeah, let me be clear about something. The staff came to me with this issue of upcoding, which we have some experience with in our auditing and our...
We made him talk about it.
Yes, you did make me talk about this. Upcoding has to deal with the fact that when a physician or their staff is seeing a patient and they are seeing them for a particular condition, in order to be paid more, they will use certain codes called CPT codes or clinical practice codes that effectively pay them more for doing it. It is not a physician issue that's bad, a health plan issue that's bad, a patient issue that's bad, or any other issue that's bad. It's a system-wide problem that occurs, not everywhere, but in many cases, that has to be addressed. So we're here to talk about it, not because we're here to slam anybody. We're trying to understand what's going on and try and talk about that as to how it happens.
So in layman's terms for you, there's a certain code that a doctor uses and they bill either insured or some other government-issued insured where they pay the doctor for those procedures being done.
That's correct.
Right?
That's correct.
So why does this upcoding occur? Why does it happen?
Well, right now the healthcare system is predicated on the volume of things that a doctor does.
Right.
So for everything that they do, including when they see a patient and they are reviewing that patient's care, they're getting paid. There have been discounts that have applied from Medicare, certain discounts that have been applied in each state with regard to state Medicaid programs, and many physicians have been against that because effectively it's decreasing the amount of money that they get. At the same time, same thing has been done to pharmacy, same thing has been done to hospital. So it's not just a physician issue, but in this regard, there is some leeway that happens in the CPT code billing that you don't see necessarily with regard to pharmacy claims or with regard to hospital claims.
Right. So when this upcoding does occur, when a doctor is billing these insurers, patients won't be able to see it. In most cases, they don't even know what's going on. They just see their insurance paid for something the doctor did, and not necessarily knowing something is nefarious is going on.
Yeah, I mean, I think it's fair.
If it's nefarious. I mean, I'm not... I don't want to cast any aspersions here.
When the staff brought this to me, my major issue was, does anybody care?
Right.
Now, Pharma cares because we deal a lot with the analytics and auditing and stuff like that. But does anybody else care? And it's really an issue where you're looking at this and you're saying the health plan has to pay more. The patient may or may not pay more, probably won't, but certainly it may influence their future care because they're adding complications to whatever was seen. And now the patient is going to have to be evaluated for those complications as well.
Right.
Potentially there's a problem with insurability in the future, depending on what kind of diagnosis the patient has been given. And there may also be issues with regard to the type of care that someone is getting. I had a physician tell me once that a patient was, or on the chart, the patient was diabetic. And when we questioned him in a utilization management team, the patient was not diabetic, but the group, his staff, had upcoded it in order to deal with getting the claim through. This is a bigger problem. It's not just a physician issue or otherwise, because patients may or may not notice it. and in general probably won't even know it's happening. The health plan probably won't know it's happening either.
Yeah.
It certainly leads to increased cost, but there's a larger issue here, and I think we should talk about that as well.
Yeah, and then that larger issue among them would be trust.
Yes.
Maybe you go to a doctor, you trust that you're getting the right treatment, you trust the right codes are being utilized, and then if you go from what a lot of people do, go from doctor to doctor, that next doctor is not going to know what the true procedure or the true diagnosis was on this side.
Yeah, and I think to be fair here, this isn't universal. It doesn't happen 100% of the time. It doesn't happen 50% of the time. I honestly don't know what percentage it happens in, although in many of the cases where Pharma has reviewed things, there's been a certain amount of that. But the real issue here is the idea of being paid on every instant of what you do versus being paid for the value of what you do. Exactly. And that's where we really get into the structural problem that we're dealing with as to what are we looking at and how are people being paid in order to try and remove some of these adverse things that are happening in some percentage of what goes on.
Right. So how do we go about this in the future? How do we go about checking these doctors or making sure that there's some safety guidelines in between that'll help these doctors put in the right code?
Well, ultimately, there's a move in healthcare, and I think it's really important you brought that up because it was the thing I was most concerned about talking about this because of the concern. I didn't think anybody cared, but the real issue here.
Some of us care, Craig.
Some of us. Okay. The real issue here is the volume to value movement, and that is people are looking at this and are saying, I don't just want to pay because you work hard or because you are billing for all of these things, but rather, am I getting any value out of it?
Right.
As they do that, then they move to a set fee that a physician gets. In that regard, there's a significant move to try and limit the amount of things they do in order to ensure the fact that blood pressure is in control, diabetes is in blood sugar is in control, thyroid function is in control, etc., in order to try and address this thing. Now, Pharma has seen this.
Yeah.
Pharma has seen it because in our auditing functions, we have issues with regard to specialty where a lot of this occurs, with regard to the cost of some of these drugs that are hugely expensive, upwards of $1,500 a dose.
Yes.
And our fee schedules in order to help payers, physician groups, and physicians in order to bill correctly. And by the way, physician groups are frequently overlooking what's going on with all the doctors that are part of their networks to see what's going on. So everybody cares about what's happening here. But at the same time, we've also seen where as we move to value, and we've done several programs, we did it certainly in the early 2000s when we were dealing with it in the coal mining areas of West Virginia, Illinois, Indiana, Wyoming, all of that. Right. We saw it other times over the past several years where we've dealt with it with groups that are dealing with employer-sponsored programs and how they're handling it. At the end of the day, though, everybody realizes that we need to move away from being paid for every individual thing that you do and take that incentive away and put it into the issue of give me the value. The difficulty in that is defining what the value is. And clearly there's a lot of people looking at that right now. But that ultimately is what has to happen.
Right. You have to focus more on the value than the volume of care, right? So, but there's also these state-funded insurers, right? You got Medicaid, you have Medicare, and if you're upcoding these patients and paying a lot more for these procedures that didn't really take place,
right?
So, how does that impact the patients overall in each state?
Well, first of all, Medicare is a federal program. Everybody puts in money and it's paid for through federal taxes.
Right.
So the more that people upcode and the rest, that means everybody has to pay.
Exactly.
If it's a state Medicaid program, then similarly to what goes on from state revenues and state taxes, everybody has to pay for that. So nobody is immune to this, but probably most people don't even know that it exists. It's only more of an issue that comes up on audit. It comes up on issues where we're looking at problems and we see it. We are perhaps uniquely involved because we see it perhaps more often than other people do.
Of course. Right.
But at the end of the
only
day,
ones really looking.
well, there's others looking, but there's a but there's a smaller percentage of the problem. So it's not like it's the main problem you're always looking for.
Right.
It's a problem that occurs, and you have to try and figure out how to deal with that, whether it's lowering cost for a health plan or otherwise. Because you've identified it and now it has to be corrected. It also, by the way, in what we're doing in fraud, waste, and abuse in our FWA programs, where we're dealing with prevention as a really suggested and mandated under Medicare and also under Medicaid programs, we're tracking these things on a regular basis and identifying where people have they seem to be an outlier versus other people treating the same condition, same severity, same geography, and they come up, and so we see that there as well.
Right. So, but going back to these federal and state-funded programs, but people see that the new published results are healthcare costs keep rising. Everything keeps rising. All these procedures are costing a lot more. All these drugs are costing a lot more. Are the people going to start demanding more transparency over state and federally funded programs?
Yeah, that's a great question.
Yeah.
Transparency is certainly the name of the day.
Yeah.
It certainly has to deal with pharmaceutical manufacturers, device manufacturers, laboratory, etc. So yes, transparency, everybody is looking at that very carefully with regard to health plan issues, very carefully with regard to manufacturer issues, pharmacy issues, doctor issues, hospital issues. Everybody's involved.
I mean, of course, you can't release the patient information, but you could still release the financial data that how much are they spending on these devices? How much are they spending on
and that goes on today, and it's gone on for several years, where it's being published, whether it's by Medicare or some Medicaid programs, private insurance, etc. Yes, everybody's going to be looking for transparency. The thing that we need to be careful with is, yes, costs are going up, but you can't attribute all of this cost increase to upcoding. You certainly can identify that perhaps there's some subset of it, and perhaps it's a very small subset of it. But issues with regard to drug price increase is not about upcoding. It's about issues with regard to people that are charging more than the contracted cost is. We see that all the time because of the work that we do on a daily basis. With repricing these kind of things. There's issues with regard to doctor fees, and as I've indicated, that's more of a volume to value kind of argument. Similarly with hospitals. It is also one of the reasons, not the only one, but it's one of the reasons why at least 80% of all physician practices now are owned by hospitals or corporations. Because from a corporate standpoint, there's a need to ensure the fact that everything is transparent, that there's a minimum of fraud, waste, and abuse. There's a minimum of this kind of abuse of the entire system. So they're interested in trying to cut that out. So the individual problem effectively moves away and it becomes a larger issue. So all of that transparency issue, that's the name of the game now. Everybody wants transparency as to what's the cost of anything. And we're obviously... we as an industry in the pharmaceutical area are obviously involved because people want to know how much do drugs actually cost. And where's all this cost coming from? And then, of course, negotiating, trying to bring this cost down.
As with anything, I mean, you're paying money, you want to know what you're doing with the money. You want to know what you're getting in return, or if you're not getting anything in return, where is it actually going? I mean, it just makes sense. And so what... the viewers at home, what can they do? Because a lot of them, I hope you're going to see your doctor. But a lot of them at home, they want to know when they're going to the doctor, are they getting the right care? What can they do to prevent upcoding or issues related to that?
Well, I think number one is I don't think that there is as much a case where they're not getting the right care. Hopefully they're getting the right care.
Of course.
If somebody is upcoded and has added something to it, then hopefully that physician or the group, or nurse practitioners, physician assistants, or otherwise, will try and correct that problem and address it. But every patient should ask their doctor, what's my specific diagnosis, what was done to me, and when I see the bill, the opportunity for me to question it. So I can ask, what was all the costs involved here? You're talking about complications. We didn't talk about complications. What does that mean? And every patient should be asking those questions. Everyone. So if people are really interested in transparency, then they should be questioning what goes on. Same thing they do with hospital bills, and the same thing that they're doing today with pharmacy bills about why does this drug cost so much?
Exactly. And don't just look at the hospital bill and see insurance paid such and such amount and it doesn't make sense, or if it's a really large number. Don't be afraid to ask questions. Ask the question of the doctor or the hospital or the clinic, or ask the question of the insurer as well.
Yes.
Right. So that's all we have for you today. Thank you very much, Dr. Craig Stern.
Thank you.
And thank you at home for watching. I'd like to remind you to hit the subscribe button, hit the little bell for notifications, and also please visit ProPharmaConsultants.com. We have a free information page called RxInfoX, and we'll have a new video for you every Friday. So we'll see you next week.